This episode was recorded in Q4 2025. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
And as Ciara's pointed out, there are varying ways that you can provide a care based on a woman's needs in whatever geographic part of the country she lives on.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Marr. Today I'll be discussing early medical abortion, or EMA, in the primary care setting with two experts in women's health.
So my name is Ciara McCarthy. I'm a GP in Cork City and I'm the HSE and Irish College of GPs GP lead in women's health.
Hi, my name is Laura Cullen. I'm a GP in Bantry and that's in West Cork, and I'm the Director of Women's Health for the Irish College of GPs.
Ciara and Laura have a wealth of experience in this area, and over the next two episodes we aim to provide a solid grounding around all aspects of early medical abortion in primary care in Ireland. We will refer to the Irish College of GPs Quick Reference Guide, Early Medical Abortion, Top 10 Tips for Non-Providing General Practitioners, which was released in 2022 and is now available to all members from the college website. I'll include a link to this QRG along with the usual chapter markers and links to other resources mentioned in today's show in the show notes. And on a personal note, I found the QRG invaluable not only in preparing for today's show, but also in broadening my own understanding and knowledge levels around EMA, and I would encourage interested listeners to take a look. In today's episode, which as I say is part 1 of 2, we discuss some EMA fundamentals, including legal obligations for GPs and considerations for conscientious objectors, HSE My Options, the 3-visit structure of EMA provision in primary care in Ireland, including considerations for geographically isolated and vulnerable populations, the importance of certifying a pregnancy, and as a sidebar, please note this can also be done by non-providers, how to determine whether an EMA is complete, and medications used, their mechanisms of action, and symptoms that the patient may expect to experience following administration. Then next week, in part 2, we will move on to potential complications during or following EMA and how to diagnose and manage these, an approach to patients who may express ambivalence about their options, including appropriate signposting to aid decision-making, contraception considerations, and we'll wrap up with some practical tips on starting an EMA service should you be interested in doing so. And before we begin today's show, don't forget that you can record podcast listening as work-based learning in your PCS e-portfolio, with each hour worth 1 credit. And speaking of PCS, we've added a podcast listener poll on the PCS e-portfolio page, inviting listeners to vote for a future podcast topic based on feedback that we've received so far through the podcast@icgp.ie email address. And thanks to all of you who've reached out to us so far. The choices on the poll are acne, HRT, obesity, sepsis and summer sickness, and we've already received several hundred votes, so do get voting if you haven't done so. And now on to today's show. I began by asking Ciara how the term early medical abortion, or EMA, fits within the broader topic of termination of pregnancy.
So TOP is still very much a relevant term, but EMA, or so early medical abortion or medical abortion, as the kind of terms can be used interchangeably, is a subset of termination of pregnancy whereby medications are used to induce the abortion. The other types of termination of pregnancy would be surgical termination of pregnancy or a procedure called manual vacuum aspiration, which is usually carried out under local anaesthetic in a clinic.
And am I right in saying part of the distinction between EMA and TOP is that EMA can only be conducted up to a certain timeline in terms of the gestational age?
So I suppose EMA can only be conducted up to a certain timeline in general practice in Ireland. So I suppose the only type of termination of pregnancy that's provided by GPs in Ireland is medical termination or early medical abortion. And the legislation in Ireland that we operate under is called the Health Regulation of Termination of Pregnancy Act. And this was enacted at the end of 2018 before the service came into being in 2019. And it's section 12 of that act that's really relevant to GPs. And that provides for termination of pregnancy in early pregnancy. And the legislation classifies early pregnancy as up to 12 weeks. So I suppose that's the legal framework that we operate under. However, we also operate under a clinical framework. And within that clinical framework, we can provide in general practice, provided it's safe and there's no contraindications, medical abortion up to 69 days or 9 weeks and 6 days of pregnancy. That would be the last date. But as I mentioned, the legal limit is 12 weeks. So women can undergo medical termination under Section 12 of the Act in hospital between 10 and 12 weeks.
So the key date then for GPs to consider is up to 9 weeks and 6 days, as you said. And then once you get to the 10-week mark, it's for hospital care. Is that fair?
That's correct, yeah. I suppose women who present and are 10 weeks or more at gestation will go to their nearest hospital unit and they'll be able to discuss their options there. And it is important to say as well that women who are less than 10 weeks, some women may prefer to consider a surgical termination or a manual vacuum aspiration. And that can also be discussed with their local maternity unit, although there isn't universal availability of these services across the 19 maternity units.
Laura, Ciara mentioned there about the woman presenting at gestational age X and which direction they may go. And of course, there is a component to termination of pregnancy in terms of conscientious objection. It is important to highlight that there are some ethical and medical considerations for every general practitioner in Ireland. Isn't that right?
It is, of course, John. So we do have an ethical and legal obligation to provide some care to women, regardless of our own ethical standpoint. So the current medical council guidelines state that we must give the patient enough information to transfer to another doctor in a timely manner if we're not in a position to provide the care that she's requested. And it's really easy to discharge our duties from that perspective. All we have to do is give the My Options helpline number. That's 1-800-828-010. And that will fulfill our responsibility to that woman. Some GPs might be comfortable referring to a local colleague who provides early medical abortion services. But again, that's each individual GP's decision to make.
I suppose it is just important to say as well that no GP is under any obligation to provide this service. So while you do have ethical obligations to fulfill, there is no obligation to provide this, and the Irish College of GPs would fully support their members in that. But we have found that, there is a good degree of kind of local referral happens when a woman presents to a non-providing GP. But I think the majority of women seeking care actually probably seek that care directly through the My Options website or helpline. And I suppose, Laura, it might be helpful for us as well to clarify what My Options actually does, because providing names of providers is only one of several duties that it serves. It also provides non-directive crisis pregnancy counselling to women, whether they're considering a termination, continuing a pregnancy, or perhaps pursuing adoption. And women can do that virtually on the phone, or they can be directed to a local HSE accredited provider. As Laura mentioned, GP providers can be given out to women. They'll usually be given maybe 3 names of local providers, so that if one is on annual leave or is unavailable, that they can still access timely care. And there's also a 24/7 clinical support service for women who are undergoing termination of pregnancy, where if they have a concern that, maybe they're bleeding too much or not enough, or is their level of pain normal, they can contact the My Options helpline, and they'll either be reassured or advised to contact their GP the next day, or they may be directed to their local emergency room.
Just to add to that, the out-of-hours component of the My Options service is a phenomenal safety net for both patients and their doctors alike. We all know that things can go wrong after any procedure. And if this happens to a woman after an early medical abortion at 2:00 in the morning, she can pick up the phone and get immediate medical advice. And that helps us all sleep easier at night. I think another important thing to discuss as well is that we do have an obligation of care to women presenting following early medical abortion or termination of pregnancy, potentially in an out of hours setting, if she has complications. So even if it is your own ethical standpoint that you do not want to provide abortion care, which is your individual decision, should a woman present to you unwell following one, you do have an obligation of care to that woman. We also have an obligation of care to women following EMA to manage their future reproductive health. So we can't allow a previous history of early medical abortion influence the care that we provide to that woman from a reproductive perspective in the future.
Okay, thanks to you both for all that clarification. And am I right in saying that My Options is underpinned by clinicians?
Yeah, that's absolutely. So it's funded by the HSE. All of the counsellors that are accredited with My Options are HSE approved and will provide non-directive counselling, and can also provide post-abortion counselling as well, or post-crisis pregnancy counselling for women who continue a pregnancy. And then, as we said, the third facet of that helpline is the 24/7 clinical support, which is usually staffed by an out-of-hours nurse or midwife.
As members of the Irish College of GPs, what we're trying to do is to help to provide education for as many of our members as possible. So for those conscientious objectors, there is quite a lot of useful information, I think, just by understanding that the My Options service is there. And I'll put a link to the My Options service in the show notes too, for people to be able to refer to. But that they can discharge their duties in the lion's share of cases simply by signposting to My Options, so that the woman can get further care through a provider. So I think we've covered the medical and ethical obligations pretty comprehensively there. What I'd like to do now is maybe spend a little bit of time going through this really useful Irish College of GPs document, which is called Early Medical Abortion, Top 10 Tips for Non-Providing General Practitioners. It's a guide that's simple and quite quick to read, but is a real mine of useful information for all GPs, I feel. To kick things off, one of the big things that stuck out to me from the top 10 tips was the fact that even if you're not a provider of an EMA service, visit 1, which is the time when you certify the pregnancy, any registered medical practitioner can provide that service. Laura, could you speak to me a little bit more about that aspect and the benefit of being able to provide that service, even if you're not going to go ahead and provide the full EMA service?
So I think that is something that a lot of GPs and other doctors aren't familiar with at all, but you don't need to be an EMA contract holder to be able to sign the certification form. The certification form is a legal document which is available on the college website and also from the Department of Health. And what it effectively does is it starts a 3-day wait, which is the legal parameter or time frame that the woman has to wait before she can proceed with the abortion care. You can give the original copy of the document to the woman that she can then take away with her before she sees the next doctor in 3 days or so. And you should also keep a copy for your own records. And I think that's all from my perspective. Kira, you might have more to add to that.
Well, what I was just going to say was actually for non-providers, it might be helpful for them to know what does the certification form actually do. And what it does is it certifies the gestation of the pregnancy in good faith. So for most women, that will be if they have regular cycles and they haven't conceived while breastfeeding or using hormonal contraception, that will be based on their last menstrual period, in that there are plenty of high quality studies which show that last menstrual period correlates very well with gestation on ultrasound in women with regular cycles. So for most women, or they may even know the date of the unprotected intercourse that they've had, and it's the only episode they've had since their last normal period. So for many women, you will sign that certification form in good faith based on the information that's been given to you. And that is what the certification form does. It certifies that the pregnancy is less than 12 weeks of gestation. Obviously, for a certain cohort of women who maybe have irregular cycles, were using hormonal contraception or are breastfeeding, or, who weren't sure the last date of their period, they may require an ultrasound before certification.
Yeah, and I think it's also important to say that sometimes, if in doubt, you're not quite sure that the woman of her exact dates, but you may have put your hand on her tummy. You can feel a fundus. and you are referring her out for an ultrasound, it is okay to go ahead and sign it. As Ciara said, you're signing it in good faith. Nothing has happened yet. You've signed the certification form. And it's particularly useful for the woman if she is coming up close to dates. And what we mean by that is if she's coming close to the legal time frame after which she can't obtain abortion care in Ireland. So if you sign the certification form and we're coming tight to that timeline, then the woman isn't going to have any unnecessary weight down the line. So it's okay to sign the certification form if you're not 100%, nothing's happened yet, but you are signing it in good faith, as Ciara has said.
So that's visit 1, and it's a 3-visit structure. So for visit 1, I think we've covered everything now in terms of making that certification, when you can and when you can't. And essentially, if you can't, the next step would be to refer the woman to the local EPU service for scanning and further management. Is that basically it in a nutshell?
I think it depends on your area. And as you've mentioned, in some areas, certainly in my area, the local EPU does provide that care. So it provides the imaging that might be required in some circumstances. But also in some areas of the country, it's actually a private provider. So it's very easy to find out that information. My first port of call would be to go speak to other local providers if you're not quite sure what the scenario is in your local area, and you'll be able to find that out. The other thing you can actually do is just ring the local hospital coordinator. And again, that information is usually very easy to find out, and they will inform you of what the usual procedures are.
Okay, so we've already covered actually some of the material that's covered by the quick reference guide on early medical abortion from the Irish College of GPs. But what I might do now, if it's okay with both of you, is actually refer to that top 10. And some of that we've already covered, so I might skip through some of it just to kind of grab as many pearls as we can during this conversation. So the first point, a very important one, and Ciara, maybe you could address this. Early medical abortion is a safe, effective treatment with a high success rate and a low complication rate. Could you just go through a little bit on what the side effects are, what the likelihood is, and what makes it safe and effective?
Yeah, so I suppose the ultimate outcome, I suppose, is what we would call a complete early medical abortion. So where the patient passes pregnancy tissue at home and there's no remaining pregnancy tissue, no signs of infection, no signs of ongoing pregnancy. And how we determine an early medical abortion to be successful or complete, there's usually kind of 3 things that we'll ask a patient about. We'll ask them about their bleeding. How much bleeding do they have? And how much bleeding we expect a patient to have will depend to some extent on what gestation they are. And you know, we will have probably told them at their visit 2 and at visit 1 what to expect in terms of that, with very clear safety netting to contact us if that doesn't occur. And we also will tell them how much is too much bleeding and when they should seek emergency care. So the first thing is that we'll ask them, have they had a good bleed? The second is that if they had any symptoms of pregnancy, have they resolved? And we know that there are studies looking at this, and that symptoms of pregnancy after early medical abortion, if it's successful, that symptoms will resolve within a matter of 3 or 4 days. So it is a really sensitive marker, actually, that the procedure has gone to plan. And then the third marker that we use to deem an early medical abortion as being complete or successful is a low sensitivity pregnancy test. So these are a very particular pregnancy test. They're different to the pregnancy tests that we use to confirm pregnancy. So the ones that we use typically to confirm pregnancy are what are called high sensitivity pregnancy tests. And they will detect urinary HCG at a level of 10 if you're using the really sensitive home kits, to probably around 25 with the ones that we're provided with by the HSE. A low sensitivity pregnancy test, however, only detects HCG if it's over 1,000. And that's really important because I suppose after an early medical abortion, it can take 4 to 6 weeks for HCG levels to return to normal. However, we have a very good marker that if it comes down below 1,000, and it will fall very quickly following administration of misoprostol if the procedure has been successful, usually by about 50% at 48 to 72 hours post-misoprostol, and by 70% at 5 days. So we do this low sensitivity pregnancy test 2 weeks later. And once the HCG is below 1,000, that sensitivity pregnancy test will be negative. And then you combine that with resolution of pregnancy symptoms and a history suggestive of a good bleed and potentially passage to products conception. And that adds up to a successful EMA. The rates of successful EMA do vary a little by gestation. It is slightly more effective at lower gestations, so 98% effective at gestations of 7 weeks or less, and drops a little in the kind of under, the 7 to 10 week cohort. It's about 96% effective. And that's why it is so important to safety net women, so that we can detect either an incomplete EMA or an ongoing pregnancy, and so that they can complete their care while still under the limits of the legislation that we operate under.
Thanks for that, Ciara. That's very comprehensive. And Laura, Ciara was mentioning there and mentioned mifepristone and misoprostol. Would it be okay for you just to give us a kind of a brief overview about how those medications are administered and in what sequence the woman takes them to undergo EMA?
So mifepristone is a competitive progesterone receptor antagonist, and it's the first medication that's taken. As we've already said, the woman needs to wait at least 72 hours from the point of certification of her pregnancy to take this medication. It's usually taken in the office with you. You dispense the medication after the woman signs the consent form. And what she does is she literally just swallows it down. And how it works is it detaches the uterine contents from the wall of the uterus and can help soften the cervix. There is usually very few side effects from a mifepristone perspective, which is reassuring for the patient, given that it's the first medication that's taken. What is really important, both in the consent, and I reiterate it several times during that visit to consultation, is that it is the medication that effectively ends the pregnancy, and the patient needs to be clear on it. You cannot reverse the procedure once the mifepristone is taken. And then misoprostol is the second medication that's taken, and it's usually taken within 24 to 48 hours after the mifepristone. Misoprostol is a synthetic prostaglandin analog, and how that works effectively is that it causes uterine contractions and helps the woman to expel the products of the conception. We usually take misoprostol buccally, and the woman is given, I should say, apologies, I should have said this already, the woman is given the misoprostol by you to take home with her to complete the procedure, as I said, 24 to 48 hours after the mifepristone. Because of the nature of misoprostol, it tends to cause more side effects. As I've already mentioned, we would expect cramping, but we also will have bleeding, usually within about 4 hours of taking the medication. But a mild fever, nausea, and diarrhea are common enough side effects, and counselling the woman about those is important. I generally always advise and prescribe as well analgesia to help deal with the effects of the misoprostol. So usually ibuprofen, 600 milligrams, if that's suitable for the woman. And as I've stated, the protocol is that we generally recommend is that the patient takes the mifepristone, and then 24 to 48 hours later, she takes the misoprostol. But there are other protocols. But for the purpose, I think, of this podcast, I think it's important to keep it simple. So we'll just explain that protocol. But there are other protocols whereby kind of timing and staging of those medications can be changed around. But usually when you're starting off the process, and certainly when I was starting off my own EMA service, I kind of stuck to what was recommended until I was very comfortable with that and understood when the other protocols were maybe more appropriate.
From my own perspective, having not been through this process myself in my own practice, what I'm interested in knowing, Ciara, is does the patient have to be in front of me for visit 1, visit 2 and visit 3, or is there some leeway there?
So the HSE's model of care for termination of pregnancy services was, I suppose, initially updated in 2020 in light of the pandemic. And that was an interim model of care. And that was transferred into being an enduring model of care in October 2023. And what that does is it allows, I suppose, for an enduring facility whereby EMA can be delivered in a blended fashion. So where some of the visits will occur on the phone or via video consultation and some will occur in person. And in practice, I suppose if GPs are using a blended approach, and not all GPs do, some GPs still choose to see women in person for all 3 visits, and that is their individual choice and prerogative. But the most common visit that would be conducted virtually would be visit 1. And the reasons it is, I suppose, conducive and amenable to being a virtual consultation is it allows for that visit 1 to be done in a really timely way, because it can be often done maybe at the end of a working day, and it allows for the certification form to be completed and that legal 3-day wait to begin. Most providers will then conduct visit 2 in person, and they'll undertake their physical examination at visit 2 instead of at visit 1. And that's really important. Again, it is just cementing your certification that you are happy that that woman is less than 12 weeks gestation. You've put a hand on her abdomen. You can't feel a fundus, and this is, in keeping with the dates given. There is a facility within the model of care for fully remote provision in extenuating circumstances, but since the pandemic, I suppose, since things like isolation rules have eased up, really, I'm not aware of any GP providers that would be using this. And obviously, in those really extenuating circumstances, you would need to be very clear on safety processes and safety netting. But most GPs, many GPs, I would say, are using that blended model to streamline care, I think, for the woman and for their practice as well.
And that's a really useful point for me as well, Ciara, in terms of, again, going back to that visit 1, even if you're a non-provider, the woman meets the criteria in terms of regular cycles, being certain of her dates in the usual way, it is okay to certify, and then your colleague who's potentially providing the EMA service can do the physical examination and do the additional work to confirm that this is an appropriate intervention at this time for this patient.
Yeah, correct. And again, I suppose it's just going back to that wording on the certification form, which is, in good faith. And I think, you can do that based on history, and then it's supplemented by your physical examination.
So just to add to that, I think sometimes what you do and don't do in person is very much so guided by how well you know a patient. So if it's a patient you have a nice, trusting doctor-patient relationship with, then you might feel more comfortable providing some of the care remotely. I think if you're not very familiar with the patient, or the patient maybe is more vulnerable, you might be more inclined to request that the patient presents to you for all the visits. I think what's important here is that the principle of a GP using their instincts absolutely plays out in this scenario like it does in many other medical scenarios, and don't be afraid to trust your instincts.
And I think as well, Laura, as a rural provider, you probably are very familiar with this, in that some women, particularly in some areas, where we come from a very well-served area of GP providers in Cork, but I work in an urban area, and I suppose the geographical distances to travel to a provider are not huge. Whereas there are areas of the country where there aren't as many GP providers, and women may have, to travel a significant distance to access care. So and I suppose they're juggling that then with working responsibilities, childcare responsibilities, other caring responsibilities. So being able to access one of those consultations virtually can be really, really important to them being able to access care at all. So again, I think just keeping, obviously you have to work within your own comfort, and, again, that sometimes, the gut feeling you get, but keeping the woman at the centre of this always, and making this process as streamlined as possible for her is really important too.
No, absolutely. I do agree with that. And I've certainly had several circumstances where women have lived far away from my practice, but I was the closest provider for them. So I've had women who've lived an hour and a half away from the practice who I would have dealt with visit 1 on the phone, seen them for visit 2, was very happy to proceed at visit 2 with the procedure, very happy to dispense out the misoprostol to take at home, and then given a low sensitivity pregnancy test to the patient, who's then taken that test 2 weeks later as instructed and rang me to confirm that the pregnancy was over. And I would have spoken to her on the phone and gone through the various questions that are appropriate there for visit 3. And as Ciara's pointed out, there are varying ways that you can provide a care based on a woman's needs in whatever geographic part of the country she lives on.
Many thanks to Dr. Ciara McCarthy and Dr. Laura Cullen for participating in today's show. If you have any comments or feedback, or indeed suggestions for future topics, we'd love to hear from you. Please email us at podcast@icgp.ie. As I said at the outset, part 2 of this 2-part series will be released next Wednesday, that's the 17th of June. And until then, many thanks for listening and take care.